Am I good to go now? All right, everybody, I just want to introduce our lecturer today. Okay. We have Dr. Osman Ahmed. He's coming from the University of Chicago. So a little bit about him. He finished his medical school at University of Illinois, with residency at the University of Chicago, graduated in 2014, finished fellowship in 2015 at Stanford, was at Rush for 3 years, and then has been at the University of Chicago ever since. Is currently an associate professor and has received numerous awards, so including JVIR Editor Reviewer of the Year 5 years straight from 2016 to 2020, and has published over 100 articles. I'm not going to go through his entire CV, but I just want to thank you so much for coming down.
Thanks, Dave. Yeah, appreciate it. Thanks, Dave. Yeah, you can just take away from that. I'm a huge nerd. That's really, that's all that means. So I'm going to sit because I think it'll be easier. That's okay with everyone to just flip through these slides. I have, first of all, thanks Dave, Weil, and the rest of the crew for sort of inviting me to give this lecture. And it's quite the privilege to sort of have this opportunity to talk about something I'm super passionate about, which is basically, treating DVT and PE and doing that through minimally invasive methods. So we're going to take a little bit of a different course than probably most DVT PE lectures that you'll see nowadays, which is basically clot on a napkin or on a gauze and then picked in just really pretty pictures. If anything, we're going to sort of really dig into the data and really not talk about clots so much. So this is more of a eat your vegetables type of lecture, so it might be a little bit boring, but I think for a lot of us, especially if you're earlier in your career, if you're in training, it's really important to understand why we do what we do as opposed to just having the ability to do it, So let's start off. Let's talk about VTE in general. Venous thromboembolism. It's a major public health problem. Anywhere you read about it, any layperson will know what a DVT or a PE is. It affects about 1 to 2 people per 1,000, and greater than 50% of it is DVT. And the overall lifetime incidence of DVT in a patient, in the prevalence-wise or incidence-wise, is 2.5 to 5%. And the primary concern around a DVT, it's a spectrum. So you start with the DVT, and basically the most sort of sinister thing that could happen is a PE, and PE is essentially a life-threatening entity. When you treat PE, it still carries a relatively high risk of mortality, about 8%. However, most patients, fortunately, with VTE won't die from these episodes. However, a very large proportion of them, 40 to 60% of them, will develop something called post-thrombotic syndrome or PTS. And PTS is a pretty devastating disease because it's something that it's hardly recognized, and it's oftentimes mismanaged because DVT is sort of treated as an acute event in the hospital. You get started anticoagulation, you get sort of sent out, and nobody sort of really follows up or really manages or treats the PTS, which unfortunately can develop many years after the initial insult. But PTS essentially is the sequelae of a vein that didn't recanalize or an obstructed vein. It results in chronic limb pain, swelling, heaviness, and as I said, it can lead to major disability, leg ulcers, and impaired quality of life. So how do you measure PTS? PTS has to be measured, it's graded through many different classifications, but the one that we probably use the most is something called the Villalta scale. And the Villalta scale, and we'll sort of start talking about some of these studies, is a method by which basically you take symptoms and clinical signs and basically put those together and you get a score. And if you have a score greater than 5, then it goes up to 30 something, I believe. You basically have PTS. And the reason I put this graph here is because it's hard to remember these things, but it's pretty easy to just see them and calculate it. And once you get into that 10 range, you have moderate PTS. And once you get into greater than 14 or 15, now you have severe PTS. There's a bunch of other classifications that exist, as you can see here. Probably the more other common ones that you'll see are the CEAP and the VCSS as well. When you talk about treatment for VTE, really the primary mainstay of treatment is anticoagulation. Anticoagulation actually works by preventing thrombus extension and embolization. So it's really effective for preventing PE because it basically prevents a clot from propagating and or breaking off and going to the lungs, and the reduced mortality from that. However, it doesn't actually treat the clot. It just basically prevents a clot from getting bigger or breaking off, like I said. So it's not very effective for treating PTS, which, as I just mentioned, for DVT is sort of your primary concern when you're treating this. And oftentimes you'll see patients who get compression apply with anticoagulation, but again, that really hasn't been shown to be very effective for PTS because of the rates still are very high. So that's all the background, about DVT, all the sort of science that a little bit that we talk about. So now, where is the role of IR? Where's the role of endovascular treatment? Where has it sort of come from? And the main thing that started was actually catheter-directed thrombolysis, or CDT, and it's basically a minimally invasive way to address this. And the way that we basically treat this is you take a small bore infusion catheter, you place it across the clot, and you directly infuse the medication called TPA into the thrombus. And TPA, as we know, is a medication that actually can break down the clot as opposed to just prevent propagation. Directly embedding the catheter into the thrombus prevents or allows you to inject a very, very small dose, and you can do it continuously over time. And so, again, TPA being a locally acting drug, if you can give it directly into the clot, you can give way less drug, so therefore it's much safer to do that. As we know, probably with systemic TPA, the rates of bleeding are much higher, and so this is a way to sort of make it safer. It does require sort of a higher level monitoring for bleeding. So that oftentimes, if not always, these patients are placed in an ICU to sort of monitor for that. So as you can see here, here's a venogram. This shows basically a large clots inside the vein here. And what you do is you can basically just, this is a pretty quick procedure. You can essentially place an infusion catheter and drip the TPA across it. So here's an example of what that looks like. This is a 17-year-old female who presented with severe right leg pain and swelling. And you can see here that I always include videos as well, just to sort of illustrate what you actually see in the procedure. But you can see there on the image on the left, there's acute thrombus sort of extending up into the iliac. And then eventually what you see here are collaterals that form, because in the venous system, there's essentially no life-threatening occlusions. Usually the veins accommodate flow back to the heart through collaterals. So what can you do? This is, again, like I mentioned, from a procedure standpoint, it's a pretty simple procedure to do, is to place in a thrombolysis catheter or infusion catheter. And these catheters, as you can see, the black marks there, that's actually what we call the infusion length. So between those two black marks, those radiopaque marks, are really tiny side holes, just like like a sprinkler for your lawn, that will sort of infuse TPA at a very low dose overnight. And so what you do is you just do that, you place the patient in the ICU, monitor their hemoglobin, fibrinogen levels, and you bring them back. And you can see here, pretty much the TPA has gotten rid of most, if not all, of the clot. And what you have really left now is chronic thrombus, or residual narrowing that we sort of use interchangeably. So what do you do to treat that? You basically can angioplasty and stent that. And sort of that's what that looks like post angioplasty stenting. And again, post stenting, you can see there's pretty good flow now. And so we've went from completely occluded femoral and iliac vein to now a reconstructed iliac vein with good brisk patent flow. And these patients are always followed clinically, but also radiographically. And in this patient, we chose to follow him with ultrasound at 3 months. You can see the stent is patent. So what is the whole, what is the reason why we're doing this? And it's all very common sense. It's like, okay, well, if you have an occluded vein, if we could take all the clot out and we can open the vein, aka the open vein hypothesis, we can actually, save the vessel from scarring and prevent PTS. And so this was really the rationale for why we do, endovascular treatment for DVT. And it's still the reason why we're really primarily treating DVT, is to prevent PTS, and behind this concept of the open vein hypothesis. What's really important to know is that this hypothesis has really only been tested in 3 major randomized controlled trials, and with some conflicting results. So let's go over those studies. So the first study is the CAVIN study. This is the first randomized controlled trial It was 20 Norwegian centers, and essentially what they did was they randomized patients with iliofemoral DVT, so iliac involvement DVT, about 200 patients to CDT versus CDT with anticoagulation versus anticoagulation alone. And what they found was that the rate of PTS at 2 years was significantly lower in the CDT arm, with the number that needed to treat of 7, which is really good. And if you look at it, that didn't come, there's no free lunch, unfortunately. That came at the cost of increased bleeding. This was still a landmark study, and it's still a study we often quote, to this day, to support why we intervene on patients, especially with iliofemoral DVT, is because this study showed in a randomized fashion that we can actually reduce the incidence of PTS. And they also looked at the patency of the iliac veins at 6 months, and the patients who had CDT were more likely to be patent. So, if you dig a little bit deeper at this study, and we'll dig it, we'll do this for the other studies as well. They actually did thrombolysis for a very long time. Nowadays it's very rare to lyse somebody more than 24 hours, but in this study, they actually lysed them up to 6 days, and the mean lysis was about 2.5 days. In addition, the complete thrombolysis rate, the amount of actually the ability of TPA to get rid of all the clot, was actually not that great. It was only about 50% of patients where they were able to sort of get rid of all the clot, which left about half those patients either with partial or failure. But interestingly enough, the frequency of PTS in that CDT arm was actually no different among the patients who had TPA. So if you had TPA, whether you got complete resolution or not, you still had a lower rate of PTS than patients who had just anticoagulation alone. And they also did a 5-year follow-up of these patients, and they saw, and this was published in 2016, they actually saw that gap of PTS actually widened, so that the patients who had CDT initially up front had 43% rate of PTS, whereas the anticoagulation arm 70%. So almost all those patients are getting some level of PTS. So it's really striking to see that over time that actually the TPA was actually that arm did better. Interestingly, and this will be sort of a common theme, is that quality of life has never been shown to be better with endovascular treatment. So even though we're reducing the incidence of PTS, we're still not improving quality of life, which we'll talk about as a potential area of improvement. So that study really was groundbreaking. Everybody's super excited about CDT. Everybody excited about endovascular treatment of DVT. And that sparked the ATTRACT trial. They said, okay, well, let's do this in America. Let's do this in let's do a larger study. Let's do it, randomized control trial. Let's look at all DVT. Let's look at DVT from the popliteal up. So not just iliofemoral DVT. And they randomized almost 700 patients to anticoagulation versus CDT with or without stenting. And I still remember this day at SIR where they had a big, kind of like a huge auditorium, and they're going to release the results. And what they actually found, unfortunately, was that there was no difference. And it was really sort of shocking to us, because you could feel the air being let out of the room that oh, okay, well, that sucks. We really thought that this was going to really say, okay, we really should be treating anybody with a DVT. We should open up their vein and get them better. And unfortunately, that's sort of the main takeaway from the study. But, if you look at the, sort of the data a little bit closer, you did see that patients that were treated that had moderate to severe PTS, that incidence was lower in the intervention arm, and specifically patients who had iliofemoral DVT. So that sort of that same initial cohort from the CAVIN study. Again, no, there's no free lunch. There's higher bleeding events at 10 days in the CDT arm. And so we know that, sort of thrombolysis or these endovascular treatments resulted in greater bleeding complications. So that's always going to be the trade-off. So they did a similar study, a follow-up called the CAVA study. This is a Dutch study where they actually used a specific type of thrombolysis called ECOS, which actually has an ultrasound mechanism to it. And they did the same thing. They randomized a CDT and CDT versus just anticoagulation. Again, they looked at only iliofemoral because that's where it seems to be that those are the patients that get the most benefit. And they lysed those patients up to 96 hours. Again, very different from the way we typically treat patients now. And they looked at PTS, and And again, this thinking of this is going to be like a tiebreaker study. Unfortunately, this also didn't show a difference in PTS. And it also showed a 5% major bleeding risk. And so, and again, they followed these patients out even longer, and still didn't show that there was a difference. And so, what have we learned based on those studies? Because those are the three major randomized control trials we have about DVT interventions. Really the main takeaway is that we don't treat all DVT. Even though the open vein hypothesis makes sense, it really hasn't borne out completely in the literature. And really the main reason probably why is that some of the vessels that we're treating, if they're too small, they're not gonna benefit from a treatment, and they're gonna come at the risk of bleeding. So we really only focus on iliac and or IVC DVT for the most part. And again, the goal, keeping in mind whenever you're interviewing these patients, so if you see somebody who's super sick, cancer, and only has 3-6 months to live, the reason we're doing this is to prevent moderate to severe PTS in the long run. So you have to keep in mind, why are we doing this? We're not just sucking clot out just to suck clot out. We're doing it to reduce the risk of PTS. So you have to weigh into the fact that, will this patient benefit? Will this patient actually live long enough to benefit from this? So, so for that reason, and again, based on some subset analysis from those studies, we really we shy away from treating patients who are greater than 65 based on that. And then we also sort of always factor in the risk of bleeding and as the cost of our intervention. And the only other sort of group to maybe consider treatment for, and again, this is more based on subset analyses, is patients who have very severe pain. CDT may be beneficial as it allows greater reduction in leg pain at 10 days. So if you've got somebody who has a DVT, doesn't matter really where it is, but their leg is really swollen, super painful, they really are struggling, then you may consider offering them intervention. So that's sort of what we know or what we've learned. There's a ton that unfortunately that we don't know. And what we don't really know is if thrombus removal with CDT really works. We have 2 studies that sort of are against it and 1 in favor. So the data is pretty conflicting. And again, I'm going to keep harping on this, but there's always complications to, potential complications to what we do. So that's going to really sort of should weigh into your risk benefit profile. So you're doing this for something that's non-life threatening, which is PTS, but you may cause a life-threatening bleeding complication. So you have to sort of continue to think about this. And for that reason, CDT actually is not really incorporated into most guidelines, except for very life-threatening thrombus, which is called phlegmasia, or limb-threatening thrombus. And unfortunately, again, we don't really have any studies that show that there's actually improved quality of life. So, how are we going to show benefit moving forward if there even is one? And then the other really main question, I think, the elephant in the room is, are we really treating acute DVT? We saw a really high rate of incomplete thrombolysis with some of these studies. And so, the question is, are we actually treating more kind of chronic organized subacute thrombus? And, a lot of procedures have evidence of vein damage and subacute chronic thrombosis in these studies. And so it's really hard to know if we're actually even treating the right category of patients. And unfortunately, it's really hard to prospectively age thrombus. DVT is sort of an insidious a disease. So sometimes patients say, oh, my leg's been swollen for a couple of weeks or a couple of months. It's hard for them to know exactly when it started. So, what's really changed since then? Up until 2015, everything that I've told you has been true. And really the only devices that we used were CDT catheters, like I just mentioned. And also these very sort of lower, smaller bore catheters called angiojet, or things that could potentially sort of get the clot out, but they weren't very effective. Since that time, since 2015, and anybody who's on social media probably knows that there's been this emergence of what we call large bore thrombectomies, these really large devices where they can actually mechanically extract the thrombus and block. And they're very easy to use. They have very good outcomes in general, and it really facilitates what we call single sessions. So they don't go to the ICU, don't do anything. They just come to your room, you take all the clot out and you send them away. And it's super popular on social media because there's this concept of like clot porn. Everybody really likes posting these pictures and showing them. And I'm just as guilty, so I'm allowed to say that. Of this is like, hey, like, look at me, look how awesome I am. And so because of that, really you've seen this explosion in utilization. And again, keep in mind, this is with all the data that I've just mentioned to you. We've seen an explosion in utilization of these procedures despite those limitations. And actually there's one specific study in JVIR that shows that there's about a 12x increase between 2007 and 2017, basically the same period that all these studies came out. despite the limitations of those studies, we've still seen a pretty tremendous increase in utilization. Again, I think a lot of this is fueled by common sense, like, okay, we can take this clot out, we're definitely helping people. But the question really is, and this is the, example of types of stuff that you're going to see. You're going to see some, shameless, industry promotion. And you're going to see, people saying, well, we don't really need data. This makes sense. Like, we're taking all the clot out and we're advancing so rapidly that, that the data doesn't have time to catch up. And so what we're doing makes sense. And again, I caution people to think about that, because we said the same thing about CDT. We said, okay, well, we're lysing on this clot and patients should be getting better. So, but I want to illustrate the example or the power of mechanical thrombectomy. This is a patient, similar kind of history, has left leg swelling, iliofemoral DVT, similar picture, right? You see some acute thrombus, and you really don't see contrast going into the iliac vein. You see all those collaterals there. Especially on the dynamic images there to your right. So, instead of lysing this patient, we can do mechanical thrombectomy with these large bore devices. And so you can see here, this is a device that actually has basically a steel cage or coring element that you can basically put above the clot, and you can sort of drag it or rip it out. And this, again, doesn't take very long. It takes maybe an hour and a half-ish to do. And you can see here, post-intervention, they're slow restore. Okay, so this patient doesn't go to the ICU, doesn't potentially is exposed to the risk of TPA and the bleeding associated with that. And you see there's flow restored. Interestingly enough, this, because you're not lysing the clot, you're not trying to dissolve it, has the potential to extract clot that of any age. So notice here in this case, there was no underlying stenosis or chronic thrombus that needed angioplasty or stenting. And so the question is with mechanical thrombectomy, are we potentially, needing to do less of that? Are we getting better patency? And again, you can see here on the 6-month follow-up, the patient has a patent iliac vein, and 1-year ultrasound looks pretty good. So, how do you make sense of all this? I think large bore mechanical thrombectomy, it really does work very well. It restores patency very fast, and you can do it in a single session. You rarely, if ever, need TPA. And I think the ability to treat any type of clot is pretty helpful. Again, knowing that these older studies, they lysed out to 5 days, they got incomplete resolution. So it makes sense that mechanical thrombectomy is getting very popular for that reason. With that said, it does take longer. These patients are on your table for a longer time. There's more patient discomfort. These are larger devices. But as I mentioned, hopefully you're getting more clot in the process. You're getting some of that more, older stuff. So how can large bore devices help? As I mentioned, less, or basically really don't need much TPA, if any, anymore, with these devices. So no ICU admission. So theoretically, that should hopefully reduce the rate of bleeding, or catastrophic bleeding. Since we're able to sort of get more clot out, get more of that subacute stuff out, are we getting, better Marder scores? Are we getting better clearance of thrombus radiologically? If you look at those studies that I talked about, there's very, very high rates of incomplete, like, as I said, incomplete thrombolysis, and or adjunctive procedures like balloon angioplasty, stenting. So, when you're doing ballooning and stenting and all that stuff, that means you really didn't get all the stuff that was in there out, or the vein is so damaged that it needs to be reconstructed. And so hopefully, does that mean that we're going to be stenting less? And, less stenting means less metal in the patients, less thrombogenic stuff that could potentially, cause recurrent thrombosis. And if you look at these studies, there's very high rates of stenting in them as well. So, it's not all, rainbows and sunshine, unfortunately. Like large bore thrombectomy is a great, has great promise, but should we be skeptical? What are the potential drawbacks? Well, if you're shoving 24 French devices into patients, or 16 French devices or 18 French devices, that has its own risk of bleeding. These are large devices. You're going to more likely to get hematomas or local bleeding. There's a real true concern that if you're taking these larger devices and sort of irritating the vein, that you may get more venous wall injury or valvular damage. And we did a session at SIR on this where we had a debate, and there's a lot of concern. There's a lot of interest around this now, with inflammation and rethrombosis, and the data is coming out now that we really unfortunately can't ignore. that certain devices can potentially, predispose a patient. They're really good at getting the clot out, but then may potentially, cause you to clot again, and which obviously is not beneficial to the patient. And the other thing is really is, one of the advantages of dripping TPA is you get all the vessels, right? You can start as low in the leg down as you want and really sort of clear all the clot. And we call that the inflow, the veins below the iliac veins or below the femorals. With these large bore devices, you really are not addressing that at all. You really can't, you usually have to go through a popliteal vein at the lowest, and you can't really treat the below the knee vessel. So there's some concerns that you're not really getting good clearance, and that may affect patency as well. So, where do we go from here? I still advocate for careful treatment. Obviously I'm very passionate about this, but I really will treat primarily patients who have iliac or IVC involvement, who tend to benefit more. So they're younger than 65, or have a realistic prognosis that they would benefit from a reduction in PTS, which means that they hopefully will have a prognosis greater than 2 years. And until new data emerges, I think I primarily, at least for me in the DVT space, I use mechanical thrombectomy to avoid the ICU stay and minimize bleeding risk. To me, that seems a little bit more intuitive, in the clot. The clot, again, as we mentioned, could be subacute or chronic. But we're still awaiting studies to really understand the role of mechanical thrombectomy in DVT and the ability to reduce PTS. So just because thrombolysis shows one thing doesn't mean thrombectomy is going to show another thing. They're two very inherently different mechanisms of treatment. And there is one trial called the Defines trial where that device that I just showed you from that case is actually going to, they're going to compare it to anticoagulation for acute DVT. So, always be wary of industry trials because of the way that they're designed, but still some data is better than no data. So it's still very, it'll be helpful to advance the field. So, as far as future areas of research and improving technique, the question is, these are some of my own thoughts, but, is open vein only a piece of the big picture? We talk about the vein being open. Yes, that's true. But I showed you a lot of videos, right? So you can have an open vein, but if the flow is poor, then maybe that's the reason why patients don't get better. So I think there's a lot more interest now about optimizing flow, getting the inflow better, patency of the vessel, following patients out long-term to make sure that the vessel stays patent, reducing the venous hypertension that causes PTS. All these sorts of pieces are important, really, and may fit into a bigger puzzle instead of just getting the vein open and saying that that's enough. There's also new technology. We talked about new devices that are coming on the market. There's also new stents that are designed specifically for the veins. And so just having new devices, new technology may allow us to get better patency and or potentially better outcomes. And then, then there's this whole concept of chronic DVT. Everything that I've showed you is acute DVT, but, we do a lot of recanalization and stenting for chronically occluded vessels. We don't really know we don't really have any data on that either. So there's an NIH-sponsored study called C-Track, which is basically a chronic version of a tract that'll hopefully answer this. That's currently enrolling as well. So with that, I'm going to now, that's 50% of ET is DVT. I'm going to pivot over to pulmonary embolism or PE, try to breeze through this a little bit. But we're going to just review some existing data for catheter-based therapies in PE. And we're going to talk about the shortcomings of this data, unfortunately, similar to DVT. And then we'll talk a little bit about where we're headed. So when we talk about PE, we're really mostly interested in what we call submassive or intermediate risk PE. And the reason we're interested in submassive and intermediate risk PE is because it causes strain on the right heart. And specifically what it does is it dilates the RV-LV ratio, and it dilates it greater than 0.9. And why is that a problem? Well, there's literature that indicates that in itself is an independent risk factor for in-hospital mortality. And patients who have an RV-LV ratio greater than essentially 1 are associated with twice the 90-day mortality than those without. And if you have a very high, RV-LV ratio greater than 1.5, the PE-related mortality is almost 20% at 3 months. So it's a sort of a surrogate marker for badness, essentially, that it's going to increase your risk of mortality. So why catheter-directed thrombolysis then, or why interventional treatment? Again, there's 3 sort of big studies that really sort of showed benefit. There's only one RCT, which was the ultimate trial in 2014, where they compared CDT, again, catheter-directed thrombolysis to anticoagulation alone. CDT reduced the RV-LV ratio at 24 hours, significantly compared to anticoagulation. And again, we know that, like I just said, RV-LV ratio is a marker for increased mortality. Similarly, the 2015 Seattle 2 trial came out where they did just CDT, and they showed pre and post RV-LV ratios at 48 hours were significantly reduced with intervention. And then in 2015, there was a registry, and I was a fellow at this time at Stanford, published from Stanford, that pooled real world data and similarly showed no major hemorrhage, stroke, or procedure related complications, and also showed that the mean systolic pulmonary pressure is reduced. So if you reduce the pulmonary pressure, then in theory that reduces the strain on the right heart. And all three of these studies basically showed a very similar reduction in pulmonary pressure with post CDT. So those two slides basically are the primary reason why we intervene currently for PE patients, and particularly in the intermediate risk population. So what's happened since 2015? Very similar to DVT, right? We've seen an emergence of medium and large bore mechanical thrombectomy. And what we've seen, is a lot of industry-sponsored studies. So we've had in 2019, we had a FLAIR trial, and we also had 2021 the Extract PE. And these were single-arm, multi-center studies, basically evaluating, just saying that mechanical thrombectomy is safe and it could similarly reduce the pulmonary artery pressure. We also had in 2022 had the FLASH registry, which is the Inari device, where was a real-world registry, and again, primarily trying to document safety, feasibility, and initial efficacy. In addition, the way we do CDT has also sort of changed since 2015. Historically, we used to just put up, infusion catheters, leave the patient, for 24 hours, bring them back and sort of take it out. And those patients got a lot of TPA. They got, potentially 24 milligrams out to 2 days. Contemporary CDT, for the most part, is basically half of that now. So most patients get about probably 17, 15 milligrams with similar outcomes in terms of reduction of pulmonary artery pressures, and in theory lower rates of bleeding as well. So now in contemporary CDT trials, you'll see that the bleeding rates are almost zero, if not zero. And there's another study that this is a newer device called the Bashir catheter that they did 14 milligrams over 5 hours and had similar very high rates of PA pressure reduction. So there's no conversation about PE without talking about ECOS versus non-ECOS. So ECOS is the CDT catheter that all those studies that I just mentioned, Ultima and Seattle 2, where they used it's a proprietary device, but those are all the studies that PE intervention are based on. But the question is, does ultrasound actually truly add anything? So there's been some studies that have come out. There's a randomized control trial where they compared ECOS versus non-ECOS, just a traditional infusion catheter, and actually really saw that there was no reduction in clot burden, and that the RV-LV ratio reduction was actually greater in the traditional CDT arm. And there's actually more bleeding events in the ultrasound than the ECOS arm, although it wasn't statistically significant. In 2023, they actually did a meta-analysis. This actually came out a couple months ago, where they looked at ultrasound accelerated CDT, which is ECOS, versus just traditional CDT, and saw that there's similar reduction in PA thrombus and RV-LV ratio reduction. So you'll meet a lot of people who will tell you that just using a regular infusion catheter is just as good as ECOS, and I think a lot of people hold that view. So that's really the bulk of the literature in PE interventions today. And again, it is pretty impressive to think that, considering how often how robust institutions are with PE response programs and how much we're intervening on these patients. So what's the problem? What are the flaws with the literature that I've just mentioned, and what are those unanswered questions? So, believe it or not, essentially since 2014, there's been no large randomized controlled trial that has actually evaluated the benefit of endovascular therapy for intermediate risk PE against alternate therapy. Again, most of those studies, as I mentioned, are either industry sponsored or registry rated. And because of that, again, very similar to DVT, there's actually no level 1 therapeutic guidelines to justify the use of CDT and PE. So we operate in our bubble of thinking that everything we do is great and works. Again, as interventionists, to us, you sort of should believe what you do works, but outside of our bubble, there's a lot of people who don't believe that and want to see data to sort of to justify it. So, the issue really is that patients who have, there's three categories of PE, like I said. So there's low risk, there's intermediate, and there's high risk. So the low risk patients, they do really well with anticoagulation. They have a very good prognosis, and so it really doesn't make sense to intervene on them. The patients who have massive PE, basically the patients who are hypotensive that are essentially dying on your table or in the hospital, they have very high rates of mortality. It's greater than 50%. So it's basically makes sense to do everything and anything. We say kitchen sink. You want to throw the kitchen sink at them because they're going to die anyway. So doing aggressive therapy, again, makes sense. And there's guidelines to sort of support that. And that's standard of care to do systemic thrombolysis. But intermediate risk or submassive risk PE is pretty unclear because, again, why are we doing this? Well, if you say it's to reduce the rate of mortality, the rate of mortality in intermediate risk PE is actually only 2 to 3%. So you're going to be doing what is arguably an invasive procedure to reduce a 2 to 3% risk of mortality. It's some people say that the risks don't outweigh the benefits. And so then if you want to change the goalpost, then you say, okay, well, we're not doing it for mortality, we're doing it for morbidity. Well, we don't really know what are those morbidity outcomes that we're concerned about? What are the long-term variables that we actually can show benefit? So there's problem number one there. Another problem is the RV-LV ratio. Now, RV-LV ratio is just basically an imaging finding, right? It's just an imaging parameter, or imaging finding is a physiologic parameter. It's not a relevant clinical endpoint. It's not saying, okay, well, we improve your RV-LV ratio, you should be good. We know that obviously correlates or links with mortality, but we just talked about mortality, overall mortality being low. So if you look at a lot of these studies, we actually lack evidence for objective clinical improvement compared with anticoagulation alone. All these studies just look at RV-LV ratio. They don't really say, well, they actually felt better. They actually were breathing better. They were walking more. They were dying less. None of those things. They just talk about RV-LV ratio. And the other thing that we don't really know about with PE specifically, the DVT, it's a little bit more obvious, right? Just take all the clot out because we want to restore patency. In the pulmonary tree, it's they branch into smaller vessels, and so how important is it to remove all the clot? Because we're trying to reduce the strain on the heart. We're not trying to get a wide open vessel. So there's no correlated data between how much clot you remove and how much better patients get. There's no minimal threshold. There's no, okay, well, if you take out 25% of the clot, the patient's going to get better. We don't know. We just try to take out as much as possible, which with mechanical thrombectomy is hard because you don't know when to stop, right? And we know this is still a problem because PE readmission rates are still very high. So we do our procedures, we get clot out, we feel good about ourselves, but then a high rate of percent, it's like something about, I think it's about 30% of patients are still readmitted with PE. And the image that I'm showing you here is from the Seattle 3D study, which actually showed that with, if you do thrombolysis, you get more of the smaller vessels. And that's actually where more, obviously, the gas exchange is going on, and the pulmonary vascular resistance is actually out in the smaller vessels. And so there's an argument that actually, treating small vessel disease is more important than those large, central PEs, especially if we're concerned about long-term outcomes. And again, if you look at all the published studies, these are all the industry-sponsored studies that are out there. It's actually the lytic trials that actually have shown the greatest reduction in PA obstruction and thrombus reduction as well. So, even though that's great, we're getting out more clot maybe with lysis. Does that lead to a clinically meaningful outcome? So I'm posing a ton of questions to which hopefully it will inspire people to know why it's such an interesting time and field right now, because there's a lot of unanswered questions in the sort of utilization of these procedures outpacing the evidence, but it creates an opportunity for anyone interested to sort of look into this stuff. So, the question is like, mechanical thrombectomy, same concept, versus lysis. We have very little data that compares the two, comparing mechanical thrombectomy to CDT. There's nothing in a prospective randomized fashion. If you talk to people who are very pro mechanical thrombectomy, they'll tell you, well, this makes sense because I can take my patient to the angio suite. I don't have to drip TPA. I can suck all the clot out and they get better on my table, you know. But then you'll talk to somebody who's very pro thrombolysis and they'll tell you, well, that's great, but what we're trying to do actually is trying to get as much clot as humanly possible out, and leaving an infusion catheter overnight will get rid of all the small vessel obstruction. And that's what we're actually more focused on. And then, you know, you may actually meet people who say, well, I think there's a role for both, just depends on, you know, what situation that is. And that's probably where I fit in. And the question is then, how do you select those patients out? We talked about timing of therapy and reducing the amount of clot. We don't really know how long CDT should be. We don't know how many passes you should do for thrombectomy. These are all sort of the nuanced questions. It's not very binary. It's not just like, you know, do thrombectomy and they get better, or just put a lysis catheter to do better. We don't know how long each of these things should be. Again, I talked about all these things about the minimal amount of clot, correlated data, if there's a role for hemodynamic monitoring. So what does the future hold? And so this is probably the last slide I think I have. But like I said, this is sort of an exciting time for people who are interested in this space, but because there's a lot of trials that hopefully will sort of answer this question. So if you sort of break this down, this is like my sort of weird flow chart here. You know, the first question you have to ask yourself is, does endovascular therapy for intermediate risk PE even work? So like before we even start talking about mechanical thrombectomy versus lysis, all that sort of stuff, does the actual procedure itself work? And we have a few studies that will sort of answer this. So we have PE tract, which is, you know, if you've noticed the tract sort of suffix or whatever, this is sort of, again, the extension of a tract trial, but the PE version where they're going to randomize patients to endovascular therapies, both lytics and mechanical thrombectomy versus anticoagulation alone. Then there's HiPytho, which is from Boston Scientific, which is ECOS versus anticoagulation for PE. And then Penumbra, which is the STORM PE trial, which will be their thrombectomy device, aspiration thrombectomy versus anticoagulation. So again, over the next 5 years, we'll hopefully start getting some answers for that. And so if yes, the answer is if yes, why does this work? Why do we care? Why are we going to be doing these interventions? So there's short-term outcomes, which I think HiPytho will be sort of addressing, which will be PE-related mortality. Will there actually be a mortality benefit? PE recurrence, the readmission stuff that I talked about, decompensation. So a lot of these patients can decompensate, or progress into massive PE, and then 6-minute walk test, quality of life stuff in the short term. If you look at PE tract objectives, they have some long-term stuff that's also going to be relevant. Peak oxygen consumption, New York Heart Association functional classification, and also 6-minute walk test too. So they'll also sort of be looking at these outcomes and hopefully find something outside of just mortality that we can say is improved with this with endovascular therapies. And so if endovascular therapy works, so we say it works and we find the reason why it does, then we can maybe ask ourselves, which is better, mechanical thrombectomy or thrombolysis? And really right now, there's only one study that's looking at that, and that's called the Peerless study by Inari, where they're going to be comparing CDT to their aspiration device. So I'll conclude here talking about with DVT. I think just to reiterate, endovascular treatment for DVT is geared towards reducing the post-thrombotic syndrome. The highest quality data on CDT for DVT is actually unfortunately conflicting. For that reason, we really carefully select patients who have iliac or IVC involvement and will benefit the most. So they tend to be young, have good prognosis. And I think, as I've mentioned, the mechanical thrombectomy has shifted the paradigm for which DVT is really largely treated. The verdict on this approach is still out, and I still caution people to approach it with, carefully until we get those confirmatory studies. But again, there's a lot of intuitive things for why it works. And then with respect to PE, it's a little bit different, I think. I think endovascular therapies for PE are very effective for reducing an elevated RV-LV ratio, which is a known predictor of mortality. But with that said, since those original studies in 2014, most contemporary data addresses approaches and technique, which I think might be putting the cart before the horse in terms of really trying to understand if this therapy works in the first place. But some of the things that we talked about is mechanical thrombectomy versus CDT, optimal dosing, CDT versus ultrasound accelerated CDT. but hopefully, like I showed in that flow chart, some of these future studies will really cement the role first of endovascular therapy for intermediate risk PE, and then also hopefully try to define those clinical, relevant clinical endpoints. So it's a lot of talking I just did in 50 minutes. Thank you for staying awake. Questions, comments, concerns? Yeah.
So, two questions. For DVT, a lot of people post pictures of their clots. But very few people post pictures of histopathology, documentation of those clots and the valve damage. Do you want to weigh in on the path of endothelial clot that may actually have been chronic that you're treating versus fresh clot? And sort of along the same lines, what are your thoughts on LIFU versus HIFU for endothelial damage and the risk of re-thrombosis?
Can you repeat the second part of the question?
What are your thoughts on LIFU, low frequency ultrasound versus high frequency ultrasound energy deposition on endothelium for post declot re-thrombosis?
Yeah, those are all great questions. I think we as a specialty are getting much more interested in the sort of histology and sort of venous sort of interactions that the clot has. In brief, I think what's challenging is we know that just DVT in general is going to cause endothelial damage and valvular reflux and all that sort of stuff. And so it's hard to know if it's the devices that are doing that versus just the clot, evolution in itself. I think that's probably one of the big reasons why we've failed to see a benefit of endovascular therapy in the femoral popliteal region, because this is a smaller vessel, and if you damage valves or you have damaged valves, the flow is so slow that doing endovascular therapy probably isn't going to help. With respect to your question about HIFU or low frequency, I personally don't know much about that technology. I do actually. I'm not sure if you're familiar with histotripsy, but I've worked with some of the basic science folks on doing histotripsy actually. So I wonder if it's the same concept, but it has the ability to potentially non-invasively treat the collagenous sort of components of thrombus. And we're sort of doing it in combination with TPA, because TPA can work on fibrin very effectively. So the combination we think could be very effective for treating some of this more organized chronic clot and not in a non-invasive fashion, and that may be potentially more sparing to the vessel wall, because it does spare sort of the venous architecture of the wall. So that's been my experience. I don't know much about low frequency ultrasound. Great question. So. Yeah.
Question. First of all, that's an amazing work.
Oh, thank you.
I guess with the quality of life, is there any specific factors that are limiting, why patients are saying their quality of life is not improved? And has there been any studies on minimal clinically important differences in those quality of life patient reported outcomes?
Yeah, there's another really good question. So I think the problem, I think the issue with why PTS is such a big problem is that it's very under recognized and it's very underappreciated how to treat it. So again, if you follow a patient's timeline of okay, they get a DVT, they go to the ER. Most of the time they go to the ER, they get diagnosed with a DVT, they get sent down on Eliquis or Xarelto, and they are told to follow up their PCP. They see their PCP, says, great, take this for 3 months, and we'll see how you do. Then they come back to their PCP and they say, my leg's still swollen, it's still painful. And they're like, well, we did an ultrasound, your DVT's no longer acute. There's really nothing there, nothing to do, So I think a lot of it's sort of lost in the timeline of the patient's journey, because the inpatient people cared about inpatient issues. The outpatient people they don't really, they're focused on the management of the DVT. They're not really adept at sort of treating the PTS, and those patients almost never will even make it to an IR to see if there's a need to recanalize the iliac vein or whatnot. So I think, that's probably why we see such a high prevalence, because it's not very aggressively identified and managed appropriately. And then it's debilitating because I think there's a fair amount of these patients who have pretty severe iliac occlusions and femoral occlusions that are essentially causing, venous hypertension, very limb swelling, venous ulcers, and the cost of wound care and all that stuff is very, very high, and there's definitely like economic studies on that. In terms of the minimally clinically important difference to reflect that, I'm not familiar very much with the studies on that. I do believe there's probably patient-reported outcomes on that stuff, but it is a like economically, it's a huge burden. Venous care in general is a huge burden on medicine.
Thank you.
All right, you guys get 7 minutes of your life back.